Thank you so much for joining us. It's a huge pleasure to welcome Barbara Ann Walker, who is rather wonderful and the Chief Executive of Ashgate Hospice in North Derbyshire.
I thought it might be helpful if you will allow me to spend a few minutes at the beginning just kind of setting the scene in terms of statistics and what hospices do and that kind of thing, because after 4 years in working for a hospice, it's easy to assume everybody knows and understands that, but they don't. So just as Leslie said, we care for Ashgate, is based in North Derbyshire. We provide specialist end of life and palliative care for the population of North Derbyshire. We care for about 2,500 patients a year and their families. We have 340 staff, 700 volunteers, and this year projected spend in the region of about £11 million. And I'm saying that because I think hospices sit in a slightly funny place, somewhere between the NHS and charities. Most hospices in England are charitable hospices, but they're mostly, there's a fair amount of them that, like Ashgate, are pretty substantial charities. Not big national charities, but in the local context, we're one of the biggest charities in Derbyshire, and we're not unique in that respect across the country. We are mostly funded by fundraising. 28% of our funding comes from the NHS, and that's another confusion because often people think that hospices are NHS funded, and there are some NHS charities across the NHS hospices across the UK generally, but not very many of them. And most hospices are primarily funded by fundraising, and there's a whole different provocation about the rights and wrongs of that concept, but that can wait for another day and for somebody else to do it, I would suggest. We provide, as I say, specialist palliative and end-of-life care. So we have an inpatient unit, we have community nurses, we have community therapists, occupational therapists, physiotherapists, that kind of thing. We have social workers, consultants, as you'd expect. We have a day service. Rebecca's going to help me because I've forgotten some stuff. We have a lymphedema service, so we have a whole range of services. Most of our patients die at home. So 80% of the people that we care for in their own home or in a community setting, and most of them die at home. And indeed, a lot of the patients under normal circumstances, COVID has changed it slightly, who come into our inpatient unit will go home again because they come into our inpatient unit for symptom management. So I just want very quickly to define palliative care and end-of-life care. So palliative care is often called supportive care. It comes from, this was the learning for me in preparing for this, I didn't know this, it comes from the Latin for cloak, which is pallium. And the idea of palliative care is it cloaks the symptoms that you're living with. So it might be about pain management or other physical symptoms, emotional, spiritual, psychological, and also some very practical stuff about daily living and social care and that kind of thing. And it's about support for family, for friends, for loved ones. The thing about palliative care, and this is where it becomes really important in terms of how we live with people who are dying in the community, is it can go on for years. It can go on for many, many years, and that's something that we've been aware of in hospices for quite a long time. So we might be caring for patients for 4 or 5 years before they die. And there's something really fundamentally important in that, because there's quite a lot of evidence to suggest that the earlier people can get palliative care, the longer they live and the better their quality of life. And one of the challenges that we have about hospices is people are frightened to be referred to hospice services because they think it means they're going to die. And yes, it does mean they're going to die eventually. They wouldn't be referred if they didn't have some kind of life-limiting illness, but that could be years down the line. So there's some real challenges in there. End-of-life care is much more focused on the last days and the last hours of life. It's very individualised. Again, it's about managing the symptoms, but it's about much more focused on living comfortably as you are dying, and enabling people to have a good death. And there's a whole other provocation about how you define a good death. So I just wanted to share a couple of different things. In England in 2019, so before COVID, 45% of deaths happened in hospital. Now you have to remember some of those will be road accidents, sudden death, that kind of thing. But we know that a lot of people die in hospital who don't want to die in hospital. We also know that if you die in hospital, you're much less likely to have a good death. You're much less likely to have a positive experience as you're dying, and your families are much less likely to have a positive experience. In 2019, about 25% of people died at home, and many of them will have died with support from a hospice community team. 20% of people, give or take, died in a care home. Now, we have to remember that for most people, in the care home will be their home. There's a tendency, I think, to see dying in a care home as being a bad thing. But if that's where you've been living for the last 3 years, actually that's your home, and that might be your choice to die there. About 8% of the population in 2019 who died in a hospice, so in a hospice inpatient bed. COVID obviously resulted in many more deaths at home and many more deaths in care homes. Just in terms of hospices, there are over 200 hospices in England. As I say, most of them are charitable, and they care for about 250,000 people a year, 250,000 people a year. A hospice originated as, in its very original meaning going back to medieval times, as a resting place for travellers. So the concept was that they were places of refuge where you could go and be refreshed, rest up, get some food, get some nourishment, be cared for until you were strong enough to leave the hospice and continue on your journey. And I'm saying that because I think one of the things that we've done as hospices is we've moved away from that concept. So it tends to be it's less about enabling people to go back into the community and much more about, our patients sometimes talk about feeling like we had put their arms around them. And we sometimes struggle with that concept because whilst that might be a good thing in lots of ways, it also by its nature de-skills and disempowers the person you're putting your arms around. So there's a really challenging balance to find, I think. But hospices are very much about finding and offering a way of dying that is based in comfort and dignity and pain relief and love and compassion and support. That's what hospices were essentially set up for. Cecily Saunders, who you might have heard of, who set up St Christopher, the first kind of modern day hospice in London, was very focused on that idea. And she used to talk about you are you until the day that you die. And hospices, I think it's fair to say, are very much focused on that. In East Midlands, the hospices, there are 11 adult hospices working with about 21,000 people. There are challenges, and this is where it becomes important to think about some of the community aspects of this. There are real challenges for most hospices in Ashgate. I would put our hand up to this immediately because we're very bad at it in terms of accessibility. So if you look at our patients, they're very white. We're not representative in terms of either our staff or our patients of the community. There are many people in the community who need support who we are not reaching. We're not doing it well enough. And that's not unusual for hospices, particularly more rural hospices. So what's changed? Why did we get to a point where hospices were set up in the first place? In the 1800s and prior to the 1800s, there was very little could be done about easing people's symptoms. Death often happened quickly. It tends to be as a result of something like smallpox, cholera, that kind of thing. And the average life expectancy was something like 15 years. Most deaths as a result of that occurred at home, and most of the care for the dying was done by family members living in that home. By the end of that century, medicine and nursing very much began to evolve, and hospitals began to be built. Hospitals got bigger. They began very much to become places for people to go when they were sick. And there was very much a shift to curing disease rather than caring for people who were dying or living with disease. And the obvious things are things like antibiotics, immunizations, all of that kind of thing. So many fewer people being cared for at home, fewer and fewer people dying at home. And also, I think as a result of that, fewer dead people being at home, by which I mean when somebody died at home and was cared for at home, when they died, their body would be in the parlour or the front room for people to come and visit, for the wake to happen. I remember a family wake that happened around the body, literally, that kind of thing. So you can see gradually how we witness much fewer deaths, we witness less dying, or any of us, all of us, unless we work somewhere like a hospice. We're less familiar with the process of dying. It's become rather more frightening because it's not familiar. We don't understand what's going on. And I think there's also something for me, and this is where the community aspect becomes important. There's something for me about death and aging, and that kind of notion that death equals aging and aging equals death. And as a result, younger people and the way our societies are set up are spending less time with older people in the family, in the community more generally. And as a result, I think with all of that, what's happened is we've lost sight of the fact that dying is part of living. We are all going to die. It's only a matter of when and how. But we've lost sight of that. We've lost that sense of comfort and familiarity with death and dying. We've lost that understanding that dying is actually part of living. As a result of COVID, taking all of that into account, we have seen an increase in deaths at home, including care homes, but because we weren't set up for that, and because despite an 8% increase in the number of people dying during the pandemic, at no point during the pandemic for particularly the NHS was death and dying a priority. At no point was end-of-life care a priority. Many people did not get choice about where they died. They didn't get the option of having the loved ones with them when they died. We have the impact of PPE, which I know our staff and our volunteers feel very strongly, because the power of that ability to put your hand on somebody's arm, to be seen when you smile going into somebody's bedroom, to give somebody a hug when they need it, and to have lost that, that's a tremendous loss for both patients and their families and for our staff and volunteers. So I think there's something for me about COVID where there is a collective grief and a collective trauma that we have not reckoned with yet. And I think that's going to play out for a long time, and it will play out in our communities where our communities are particularly vulnerable. In addition, when you add to that, we know that even before COVID, increased complexity, we're all living longer. By the time we die, we will have had many, many treatments, potentially over a number of years, and potentially as part of an active treatment for a life-limiting illness. So I may be diagnosed with cancer. I might have 4 or 5 years where I'm getting different treatments to prolong my life. What that means is by the time I come to actually be closer to dying, my symptom control, my pain management, all of that starts to become much more complicated. So we've got all of this kind of big ball of stuff. There's some really practical challenges. We also have some financial challenges, to be blunt, because the Cicely Saunders Institute in London reckoned that what they were projecting was a 25% increase in deaths by 2040. They think with COVID that has come back by 20 years. So we are going to see a rapid increase. We're seeing it already in the numbers of people who are dying, the numbers of people who would under normal circumstances have been diagnosed earlier, had treatment, that kind of thing, that just hasn't happened. So we really are hitting a bit of a crunch point when it comes to that kind of thing. And we only have one chance to get it right. There is only one chance to get it right. So there have been for a number of years now some different ways of engaging with communities, talking about death, getting communities involved in death and dying and bereavement. It can be really tough. It can be so isolating. There's something called compassionate communities, which has its roots in public health. Some of you may have heard of it. It's a guy who was primarily driven, still is, by a guy called Alan Kelly here, who's an Australian. And it's about communities that are compassionate in their support for people, intentionally compassionate through health challenges, through people living with life-limiting illnesses, caring, people who are caring for other people, people who are dying through death, through bereavement. It isn't about replacing health and social care services, it's about working alongside them. It's about encouraging and celebrating the care that we can provide and do provide for one another, rather than just supporting it and facilitating, but actually talking about it, naming it, celebrating it, recognising it, acknowledging it. And there's an awful lot of different kind of pathfinder projects and toolkits and resources out there that are really interesting. So I would say up front that if you are interested in this kind of thing, compassionate communities are worth a look. There's a really good project in Scotland called Compassionate Inverclyde, Inberclyde, who are really pathfinding some of this stuff in a very powerful way. I like compassionate communities. I think the fact that it comes from the community rather than from medicine and from nursing gives the community back some power. So it values all of that other stuff that isn't just about understanding from a medical perspective, from a nursing perspective, or even from a hospice management perspective. It acknowledges that when people die, it affects a whole community. The ripple effects roll out. However, and if you were at the Robin Farrow thing a few months ago, there is that thing about how do you define a community. But either way, death, bereavement, people living with life-limiting illnesses, people living while they are dying, it all ripples out into different parts of the community. Compassionate communities makes death a normal part of life, and that includes things like working with schools, working with children to make death and dying something that they understand as well. It creates experiences, or it creates opportunities, I think, for shared experiences about things like grief, and also about things like mortality and what it means to die, what it means to be dying while you're living. It also supports and enables diverse settings, diverse communities, diverse approaches to death and dying. So it becomes less about me as a white person running an overwhelmingly white hospice, trying to work with the Chinese community in North Derbyshire to enable them to do something that I think they should do. But actually it's about how do the Chinese community in North Derbyshire become a more compassionate community, and what can we put in place. And there's lots of other things that go on as well. We've got Dying Awareness Week that happens in May every year, I think. The Good Grief Project, which is doing some really wonderful stuff about supporting people who are bereaved. There's a whole load of books. I was going to take a picture and show you the size of my bookshelf. There's so many books, almost as many books about death and dying now as there are about leadership, Leslie. People like Catherine Mannix, there's some wonderful books. I will wave this one at you because I think it's genuinely really useful. It's called We All Know How This Ends. I don't know how to do it in Zoom. I take it back a bit. We All Know How This Ends, it's called, by Anna Lyons and Louise Winter. Now, Anna Lyons is an end-of-life doula. And I don't know if you've heard of end-of-life doulas. They're sometimes called soul midwives, which I love. And they're very much about being on the ground, being with people who are dying, offering practical support, social support, emotional support. I think the wonderful thing about end-of-life doulas is that sense that they rebalance the focus to making dying much more about life living. It's very practical, it's very matter of fact. And also Louise Winter is a funeral director, and I was just thinking about this over the weekend. If you think about how funerals have changed over the last 20 or 30 years, I was at a funeral during the summer, one of our trustees died, and it was all songs and jokes and daft stories. And everybody was the request was you either dressed colourfully or you dressed in Nottingham Forest strips, which I have to say a fair amount of the mourners did. So that, funerals really have changed, and there's a push now as well to something called home funerals, because you don't have to have a church. There's also something about raising awareness with people that you don't have to have a funeral director. You can transport a body yourself. There are certain guidelines that you have to abide by, but you can put somebody who has died into a van or into a truck and take them somewhere else. So we have this whole thing about the rituals, the structure that go around death. We can reinvent those within certain limitations, and those limitations are actually surprisingly small. There are festivals like Death Fest, like Absent Friends celebrations, which happens in Scotland. There's NODA, which is No One Dies Alone, which is a lot of communities have set up NODAs so that they can make sure literally that nobody dies alone, that there are volunteers around who will be with somebody when they die at home so that they don't die alone. There's a wonderful thing in Seattle, which I love, and I haven't found anything similar in the UK, called the Urban Death Project, where you can either make sure and sign up to have your body or your relatives or loved one's body composting. So there's no boxes, there's nothing. You can literally have your body or your relatives' loved one's bodies composted. And I don't know anybody else, I love that idea. Compassionate Friends is a step towards compassionate communities. It's run by a number of hospices. Predictably, it's now licensed, so you have to pay to do it. You have to pay to be registered. You have to do the same training. And that's about having volunteers in the communities who will support people. It's almost a sort of death buddy thing. I'm not a fan of Compassionate Friends, and I'm not a fan because I think hospices have taken compassionate communities and gone, well, this is how we control it. This is how, if we have this model and we train everybody to do it, we'll do it our way. There's something called last aid, which I only found out about quite recently, which is end of life aid skills. So like first aid, only instead of being trained in first aid, you're trained in last aid. You're trained to be around, to understand that, to be able to help people who are dying. Because there's something for me about death is terrible in many, many ways. For people who are left behind, that transition is a terrible, terrible thing. For the person who is dying, for the people who are left behind, it is profound, it is meaningful in both good ways and not good ways. It is also very practical. Death is very practical. It is a physical process. It is a very practical process. And for all of those reasons, I think it's fundamentally important that we start to engage and support and involve, and we take steps to make sure that communities are able to surround the people who are dying, to support, to facilitate, to be there, to make sure that death is part of what happens in a community, because actually it is. So my provocation is, given that our fear and our denial about dying and death makes us, both as individuals and as communities, reluctant to plan for our own deaths and the deaths of the people that we love, and it gets in the way of a good death. It gets in the way of us being able to define what we understand by a good death, what we want for our own death. How do we return death and dying back to its place as a natural process, as part of life? How do we build a social movement to help each other in communities with death, with dying, with loss and bereavement? And my specific provocation to each of us is, what's our first step to do that? Because we have to take a step somewhere. It won't happen if we don't make it happen. So what's your first step? What's our first steps